all of us are in the incretin phase after lunch. And diabetes, as we know, is much more beyond sugar. Its causations, associations, complications, all are multifactorial. And all of them have got great impact while treating these patients. One such complication is a very painful neuropathy, which is unpredictable. Sometimes comes at the beginning of the diabetes itself or sometimes later. And to tell more about that, we have Dr. Anish Ahamed from Perindalmanna, Kerala. Over Dr. Anish.
Yeah, respected chairpersons, colleagues and my dear friends. First of all, I thank Ganesh and team for giving me an opportunity to speak. So I think this painful diabetic neuropathy we always speak about, but it's very difficult condition to treat. So today I'll be taking you through that. So the outline of my talk today will be on painful diabetic neuropathy, what is it, risk factors, the presentation, whom we should screen for diabetic neuropathy, the diagnosis of painful diabetic peripheral neuropathy, what is the guideline recommendations, and I would conclude with the summary of my talk. So if you ask me what is the most disabling complication of diabetes, it's the distal symmetrical polyneuropathy. So if you look at the prevalence, 30% of patients with newly or non-diagnosed diabetes, and 25% is community affected, and we have data from India also I'll show you, and 30% of hospitalized patients with diabetes affected. So if you look at the Indian scenario, 18.8 to 61% of mellitus patients have diabetic peripheral neuropathy. So again, the India study from the TIDE study, which has a cross-section of 55,000 patients, 35% of Indian diabetic had at least one microvascular complications, and out of this, neuropathy was most common. So the proportion of patients with peripheral neuropathy increased with the duration, especially showing a steep rise. So this is the shown that increased with the neuropathy, and here you can see clearly the neuropathy was the most prevalent microvascular complication in it. So the problem with the neuropathy is 50% of the diabetic peripheral neuropathy may be asymptomatic. They present to you with the diabetic ulcer. So it's very, very crucial to have an early recognition and appropriate treatment. And diabetic peripheral neuropathy is a diagnosis of exclusion. So this should be our screening approach. So like you should look for the risk factors like long diabetic duration, metabolic syndrome, obesity, hyperlipidemia, and other things. Then you should look for the symptoms of diabetic neuropathy like burning pain, shooting, worse at night, hyperalgesia. And you have two types, small fiber and large fiber neuropathy. So many of our testing neglects the small fiber neuropathy. So you will come to that. Large fiber neuropathy patients normally present with joint position, proprioception, and reduced angle reflexes. So what all the history you should ask for, like other than the diabetic duration, metabolic, the alcohol abuse, the thyroid disorders and renal failure, like GI, recent changes in the diet, weight loss, bariatric surgery, underlying malignancy, chemotherapy. So all these things you need to keep in mind while evaluating diabetic peripheral neuropathy. As I told you, it's basically a diagnosis of exclusion. So it is very important to look at the history of metformin. Then other antimicrobials, especially like linezolid, chemotherapeutic agents, amiodarone, antiretroviral agents, and immunosuppressants. So these are the risk factors which are associated with diabetic peripheral neuropathy, like poor glycemic control, long duration of diabetes, older age, tall stature, hypertension, obesity, and metabolic syndrome. So if a patient has a gait imbalance or a recent reflex associated with large fiber dysfunction associated with diabetic peripheral neuropathy. So now you have symptoms, the different stages of neuropathy, like stage 1 or no clinical neuropathy. Then you have stage 2 clinical neuropathy, which is chronic painful, like which we see commonly. Then you have acute painful neuropathy, is actually rare. It's more treatment associated, like patients who are a poor control, you give insulin, they have an acute painful neuropathy. Then painless with complete partial sensory loss and diabetic amyotrophy, which presents with muscle wasting and weakness. Then late complication is the chronic neuropathy, which we see with ulcers, Charcot foot, and non-traumatic amputations. So this again for postgraduates, differentiating between large fiber myelinated neuropathy and small fiber neuropathy. So the basic test which will help you is the pinprick sensation and temperature will give you an idea about the small fiber neuropathy, whereas angle reflex, vibration sense, monofilament and proprioception will give you an idea about large fiber neuropathy. Now there is mainly, it is asymptomatic diabetic peripheral neuropathy. So patients may not have symptoms. When you do a clinical examination only you may get. And many times what this patient may have symptoms later, they become asymptomatic as they develop severe sensory loss and insensitive food. So because of the loss of symptoms, they have ulcerations and even amputation. So this is what, for small fiber neuropathy, you should do a pinprick sensation or infrared thermometers is available. Large fiber neuropathy, you can do a vibration perception threshold, or you can use it as with a tuning fork. Then 10 gram monofilament test is what we should do, and also the bilateral angle reflexes. So this is the things which we can do clinically. But if you classify diabetic neuropathy, this is how it is: diffuse neuropathy, autonomic neuropathy, and even non-diabetic neuropathies which are common in diabetes is pressure palsies, CIDP, radiculoplexus neuropathy, and acute painful small fiber neuropathy. So today the topic for me is basically painful diabetic neuropathy. So it is basically due to abnormalities in the peripheral sensory motor symptoms. So they have chronic pain and sensory abnormalities. 16 to 26% of patients with diabetes. So as I shown you, there is something called the acute painful neuropathy. So these patients have continuous burning pain more on the plantar aspect of foot without nocturnal exacerbations, like walking on burnt sand. They have erectile dysfunction and depression. This is basically preceded by severe weight loss, that is diabetic cachexia, and they subside with better glycemic control within 10 to 12 months and with no recurrence. So this is also known as acute neuropathy. One form is known as insulin neuritis. So that occurs in acute painful neuropathy following the initiation of insulin and rapid improvement in glycemic control. I'll show you the data when the HbA1c fall by 2 to 3% over 3 months, 20% absolute risk. It is basically the sudden lowering of the glycemia which results in acute painful neuropathy. So if the HbA1c is more than 4% reduction over 3 months, 80% absolute risk, and reduction in the HbA1c of more than 5% over 3 months, 90% absolute risk. So the mechanism is associated with severe nerve fiber loss with unmyelinated fiber degeneration and regeneration. And you have also epineural AV shunting with neovascularization. It improves with 3 to 8 months while maintaining optimal glycemic control. So this is regarding the autonomic neuropathy. So basically when you deal with neuropathic pain, they have pain and reduced quality of life that results in depression and anxiety and sleep disturbances. So this is the interplay between the neuropathic pain, the sleep and anxiety, depression. So whom should we screen for this diabetic peripheral neuropathy? That is type 1 for more than 5 years, or type 2 assess all patients annually. So symptoms vary according to the class of fibers involved. I have already discussed, so it is small fiber and large fiber. So most commonly early symptoms is small fiber, we have pain and dysthasias. Large fibers, you have numbness and loss of protective sensation. So loss of protective sensation is a risk factor for diabetic foot ulceration. So this is the test, but as you can see here, most of our tests normally focus on large fiber neuropathy. So if you want to look for small fiber neuropathy, either we have to do a skin biopsy or a corneal confocal microscopy is that, but we don't do in clinical practice. So most of the things like this is neurogenic disabilities, neuropathy disability scoring, quantitative sensory testing is the only one which will give you an idea about both. But your nerve conduction studies will mainly assess the large fiber neuropathy. So this is what the recommendation by the ADA. You have to do a temperature or a pinprick, tuning fork or a monofilament. So if this is loss of that is known as loss of protective sensations. So type 1 diabetes more than 5 years, type 2 from diagnosis, at least risk in at least 3 different sites on each foot. Now coming to the management of painful diabetic neuropathy. So you have either non-pharmacological therapies like exercise, reduced sedentary behavior, dietary modification, like topical creams like capsaicin 8%, patch. Then you have combination therapies and pharmacological therapies. But pharmacological therapies, basically 2 drugs are only approved by FDA for painful diabetic neuropathy. It's pregabalin and duloxetine. So the risk of diabetic peripheral neuropathy can be reduced with improved blood glucose control. Then if you look at the pathophysiological mechanisms, you have drugs, but we don't have much evidence like aldose reductase inhibitor, alpha lipolic acid is supposed to be an antioxidant, then protein kinase C inhibitors. So for all patients, one is optimized glycemic control. You control the hypertension, you control the dyslipidemia, and also avoid wide fluctuations in your blood sugars. So blood sugar control, if you look at the metabolic factors, the blood glucose control has only modest effect on diabetic sensory peripheral neuropathy in type 2 diabetes, but it's very crucial in type 1. Then control of dyslipidemia, hypertension, obesity, and is essential to reverse neuropathy. Then coming to the methylcobalamin, so vitamin B12, but like basically B12 is a cofactor for the conversion of homocysteine to methionine. Homocysteine is toxic to neurons. So if B12 is a cofactor, so it converts homocysteine to methionine, and methionine helps in methylation. So this is what I told you regarding the metformin. Metformin can cause 0.5 to 1% of patients can have vitamin B12 deficiency. So these are the different mechanisms how it causes. One is reduced B12 absorptions, then by the bacterial overgrowth, then altered B12 distribution and metabolism, and also reduced B12 by the enteropathic. Basically, it prevents the reabsorption of bile acids. So, like if a patient has neuropathic presentations, always has this vitamin B12 level also. Alpha lipolic acid is being marketed by companies 600 milligram per day, but if you look at the evidence, it's really scanty. So these are the major trials, but they have only given you some symptomatic improvement, and it's not recommended routinely, but along with the supplements, there are some data. So this is the drugs which we can do. I showed you here on oxidative stress, we have alpha lipolic acid, then at risk factors. Then we have pregabalin acting on the calcium channel blockers. Then we have sodium channel blockers, we have acting on like carbamazepine. Then selective noradrenaline reuptake inhibitors like duloxetine, and tricyclic, also you have tricyclic antidepressants like amitriptyline and imipramine. So this is how you should go for, like first you start with monotherapy. Either you can start with gabapentinoids like pregabalin or gabapentin. Then you can start with tricyclic, and either any of these drugs. You increase to the maximum dose, then still no response, you add a second line, or you can add a second line in from another class. Then if still not, if it is not still pain is there, either you can go for topical capsaicin, or opioid is actually not suggested by ADA because of the side effects and addiction probability. And when they are not responding to pharmacotherapy, you can go for spinal cord stimulations. Or you can also even try non-pharmacological methods like TENS, high tone therapy, physical measures. But the effectiveness is again questionable. So these are the drugs. If you ask first line drugs, it is duloxetine and pregabalin. Even gabapentin can be used. But second line comes is tricyclic antidepressants and gabapentin. So the ADA has selected 2 drugs from each treatment group as the first line, pregabalin and gabapentin from the anticonvulsant group, duloxetine and venlafaxine from the serotonin norepinephrine reuptake inhibitors, and nortriptyline and desamiprine from the tricyclic antidepressant groups. But the drugs which has got FDA approval is only pregabalin and duloxetine. So how should we go about? An appropriate drug to be tried first by carefully titrating the dose based on the efficacy and side effects. The lack of efficacy should be judged only after 2 to 4 weeks of the treatment using an adequate dose. But the dose is again a questionable, because what the most of the recommendation starts is to start with pregabalin of 150 to 300, and the maximum dose of pregabalin is 600 milligram. I think most of our patients don't tolerate. I think with 75 itself they have orthostatic hypotension and other side effects. But if you look at the evidence, this is what they say: start with 150 milligram, and 300 to 600 milligram is the dose for pregabalin. So a reduction of 30 to 49% is known as a clinical relevant response. So this is one you should tell your patients, that once you start on pregabalin, you are not going to get a 100% relief of symptoms. So 30 to 49% is a clinical relevant response. A reduction of 50% is a robust pain relief associated with beneficial effects on sleep, fatigue, and depression. So maximum response of 50% only for any monotherapy. Hence, analgesia combination may be useful. Most patients are on polypharmacy. Again, when you use the combination, you are going to place your patients at risk for drug interactions, which you should keep in mind. So this is again basically what a pregabalin mechanism of action. So it prevents the calcium influx. So it decreases the glutamate. So pregabalin has been assessed on the pain symptoms, and it has been found to be most effective in reducing the diabetic neuropathic pain. But again, here you see the dose. The dose is at more than 300 milligram per day. So looking at the side effect profiles of pregabalin, like dizziness, edema is one thing which we commonly see when we use, and weight gain. And this is one thing which you always look in mind, but relatively these side effects are less. So pregabalin is safe when compared to gabapentin and duloxetine. Now coming to the amitriptyline, desamiprine, and imipramine. So basically we all use amitriptyline or nortriptyline. This is what we start. Normally in my practice I start with 10 and go to 25. But if you look at the recommendations, normally the starting dose is 25 to start with. So again, the dose used in amitriptyline is also controversial. 75 to 150 milligram is what most of the studies says. And comparing amitriptyline versus pregabalin in a painful diabetic neuropathy, pregabalin was preferred by 43 and amitriptyline in 34%. The problem with amitriptyline in elderly patients, they come with urinary retention and other problems. So the optimal dosage of pregabalin for neuropathic pain in literature is 150 milligram BD, but in my clinical practice, I too agree, I don't use that much. Pregabalin is found to be safer than amitriptyline, because you can see the side effect, especially the anticholinergic, difficulty in urination, dry mouth, postural hypotension is high with amitriptyline. Now we have serotonin norepinephrine reuptake inhibitors like duloxetine. So non-inferiority, duloxetine was as effective as pregabalin for painful diabetic neuropathy. Venlafaxine has also been used, but again, the duloxetine in an elderly patients, many times it can cause hyponatremia and other problems. So, but it is as evidenced as pregabalin for painful diabetic neuropathy. So coming to the side effect profile of pregabalin, you can see, which I told you, the weight regain. Then amitriptyline is dry mouth, fatigue, headache, and dizziness. Then we have serotonin norepinephrine reuptake inhibitors like duloxetine, which causes nausea, dizziness, constipation, and dyspepsia. So there are a lot of drugs which is emerging for the treatment of painful diabetic neuropathy. These are all promising drugs like capsaicin, desvenlafaxine, but tramadol, and all those things. But I don't know how it is. Now concluding my talk, painful diabetic peripheral neuropathy is common in diabetes, which leads to chronic pain, sleep, and mood disturbances. Optimize weight, BP, and lipids to reduce the risk of painful diabetic neuropathy. Avoid opioids, clearly stated in ADA due to potential for adverse events. Tricyclic antidepressants are very useful for painful diabetic neuropathy, but most of the recommendations say pregabalin is recommended as the first line in most guidelines for painful diabetic peripheral neuropathy. Weight loss and lifestyle measures are vital. We should emphasize our patients for that. Nutritional deficiencies may also contribute, especially patients on metformin. Hence, a holistic approach must be taken, and you individualize and then decide on the treatment. With this, I conclude and I thank you.
Thank you, sir, for that thorough and clinically insightful presentation. Dais is open for discussion now.
I thank Dr. Anish for taking us through the entire diabetic painful neuropathy spectrum of diseases. The topic is open for discussion.
So do you recommend that we slowly reduce the blood sugar?
So for preventing the insulin-induced neuritis, I think slowly reducing the diabetic glycemic control will be beneficial. Because when you suddenly lower down the blood sugars, one is the neuropathy worsening and second is also your retinopathy worsening can happen.
Any indication for steroids for this painful neuropathy?
No, except you may be acute demyelinating polyneuropathy only, or you can try on steroids, or otherwise we don't have any evidence for steroids.
Continuing from the same point, is it the insulin or rapid reduction? Because it's called insulin neuritis, but is it because of insulin or rapid fall in the sugar?
I think it's due to rapid lowering than due to a drug class. But what they found is when we use insulin, if you look at the HbA1c reduction of different class drugs, I think insulin is the most potent to reduce it.
And there are many phenotypes of diabetic peripheral neuropathy in the clinical presentation. Do we have any information as to who gets which type? Because some of them are only presenting with the Charcot's disease.
So that is very difficult to answer because type 2 diabetes, we have an history before. Like pre-diabetic stage itself, the most common microvascular complications which they can get is neuropathy. So I think we need to individualize and we need more studies to catch up at that stage. And because what happens is many acute neuropathy will become chronic and they don't have symptoms. So they don't come to us for any complaints. Unless they have symptoms, they will come to you, or otherwise they will miss the diagnosis.
And other painful neuropathies being plexopathy. Now, is the treatment same for plexopathy, which is not
Sir, plexopathy is very difficult, but that is what I was showing you the data on the different presentations. So plexopathy in that case, actually they try steroids. One indications where they have tried steroids is acute inflammatory and plexopathy. But I think you have to exclude and then only make the diagnosis. So that is what, because diabetic peripheral neuropathy is a diagnosis of exclusion. So when a patient presents with plexopathy, you have to rule out all other causes, then only you can stab it as diabetic plexopathy.